My father at age 55 had a heart attack. Sir, मुझे तो बचाओ आप. I'm only 35. If your father had it at 55, it's not necessarily you are going to have it. Okay, there is genetic history. Okay, there is family history. But that only loads the gun. The environment pulls the trigger. But don't wait for symptoms to come. It's too late. If you're high blood pressure patient, if you're a diabetic patient, if you're on nicotine in any form, if you have high cholesterol, if you're a sedentary worker, if you're obese, if there is a family history, then you are and psychosocial stress, then this group of 8 or 9 risk factors, these individuals should themselves subject to the doctor and say, look, doctor, it's not a question of just heart attack. Women's symptoms are taken rather lightly. And they have atypical symptoms also sometimes. There is no gender difference. Both deserve the same importance, the same set of investigations. The changes have been very dramatic because people are doing less physical activity, more of processed foods, more of sitting. So this is how dramatically the world has changed in the last 2 decades. And sedentary lifestyle has become a way of life. Prevention has to be divided into 3 clear-cut terminologies: primordial, primary, secondary.
Hello and welcome to EastMojo. In this episode, we are joined by Dr R.R. Kasliwal, Chairman, Clinical and Preventive Cardiology, Cardiac Care, Medanta, one of the country's largest multi-speciality tertiary care providers. Dr. Kasliwal is one of India's most respected and pioneering cardiologists, renowned for shaping the field of preventive and clinical cardiology. With over 4 decades of experience, he has not only treated thousands of patients, but also trained and mentored the next generation of heart specialists across India and abroad. Dr. Kasliwal has been a trailblazer in non-invasive diagnostics and early detection of coronary artery disease, and his research on preclinical atherosclerosis is globally cited. He has led community outreach initiative impacting millions and played a key role in establishing leading cardiology departments at institutions like Escorts and the National Heart Institute. Honored with the Dr. B.C. Roy National Award and the President of India's Lifetime Achievement Award, Dr. Kasliwal's career bridges high-end clinical excellence with grassroots public health. In this conversation, we will delve into his journey, lessons from the front line on heart care, and what each of us can do to protect our hearts. Hello, Dr. Kasliwal, and first and foremost, welcome to Guwahati, and thank you so much for joining us. Let us start with the questions, if you don't mind.
First of all, thank you very much for this very nice introduction. Thank you so much.
So, I'll start with something that you are, of course, an expert on. You pioneered non-invasive techniques for early detection of coronary artery disease. So, a simple question would be like, how can everyday patients benefit from these methods, and what warning signs should prompt them to seek medical advice or even something as simple as screening?
Okay, so 3 questions you've asked in the first sentence. First of all, simple screening tests. A blood test is also a screening test. You find diabetes or high cholesterols, and also screening is of the carotids and femoral arteries. These 2 arteries are a gateway to the heart. Arteries, blockages. If there are plaques, first I started my work with intima medial thickness. Now people say no, thickness is not so correctly this thing, but plaque, that means there is a blockage already appearing in these vessels, gives at least an indicator that here is a patient, here is a person who may likely be having a blockage starting in the heart. See, the main thing you have said is most important: preclinical. Once the patient has signs and symptoms, sir, mera chhati mein dard ho raha hai, then the story is over, isn't it?
Yeah, I know.
Preclinical atherosclerosis is what I have chosen to be something which I would work till my last day, and now the whole world is talking about it.
Exactly.
They have gone to a little further. They have said, okay, and we are also doing it. We can do CT angiography.
Yes.
It is non-invasive, but it is radiology. There are X-rays in that. However, these tests can take us to that extreme that we can find out if he has the disease starting or not. But the important point is, should everybody in India have it? We are saying that in Indians, disease is very common, but we cannot subject everybody to tests.
True.
So who are those people who likely need it? Number one, those who have family history of strokes or heart attacks. You know, my father at age 55 had a heart attack. Sir, मुझे तो बचाओ आप. I'm only 35. If you're high blood pressure patient, if you're a diabetic patient, if you're on nicotine in any form, if you have high cholesterol, if you're a sedentary worker, if you're obese, if there is a family history, then you are and psychosocial stress, then this group of 8 or 9 risk factors, these individuals should themselves subject to the doctor and say, look, doc, it's not a question of just heart
Screening
attack.
has to begin with themselves first, right?
But don't wait for symptoms to come. It's
that's-
too late.
So just to clarify, when you say obese, you are using the BMI standard of obesity?
Yeah.
So anybody over 30 on the BMI scale would
No, in India, anybody over 25.
25.
Asian standards are different.
different. Exactly. So, sir, this is something that now that we are talking about screening and all, one thing that while I was researching about your work, then one thing that became clear is that a 2022 article published by the Harvard Medical School called the Heart Disease Gender Gap and said, and I quote, social and cultural factors may help explain why women don't fare as well as men when it comes to treating coronary artery disease. Now, you have had over 4 decades of experience in this field. What has been your lessons in this regard? And I also learned that the onset of heart diseases tend to be later in women compared to men. So, has your experience been different in case of India or abroad? Or
Yeah.
So,
No. Women's problems are taken not so seriously as men's problems.
of course.
Please understand this.
So, this is in the case of heart disease.
This is in the case of heart disease also. Till the lady is clutching her chest and saying, "Mujhe le chalo kahin." But again, we are 2 steps before that. Preclinical atherosclerosis. Now, in women, it's a jeopardy which starts right from birth, because at that time the family and everybody will keep on feeding the child also, and will keep on feeding women also. Women obesity is actually a little higher than men obesity. So why would they not have hypertension? Why would they not have diabetes? Why would they not have hypercholesterolemia? So please do not, when you talk of coronary artery disease, as you have specifically asked, there is no gender difference. Both deserve the same importance, the same set of investigations. And my first tests are very good, because these are totally non-invasive and there is no radiology, X-ray involved in it. So that way we are safe. But yes, women's disease, women's symptoms are taken rather lightly, and they have atypical symptoms also sometimes.
You make a very interesting point that every the list that you made, obesity, hypertension, high blood pressure, cholesterol, these are essentially lifestyle and diet based.
Yes, and
To a certain
as you asked,
cultural.
Yeah.
So if these are things that are being seen in the men, then it's only obvious that it should be checked in the women also. But yeah, exactly. Like even with blood pressure, for every 10 men that I see having blood pressure medicine, I only see 2 women having it, for example.
But blood pressure is equal in men and women.
Exactly. So, sir, this is again taking me into your work itself, but your community outreach program has reached millions across India and Africa.
Yeah.
You have also worked extensively in
Afghanistan and
Nepal
Kabul also. Yeah.
So, within now when you look back at it, of course, it's not easy to summarize all of that, but what challenges and success stories according to you stand out, and what can communities learn from these campaigns?
Yeah.
And in the same way, like you say, can you also tell us a little more about Mission Save Hearts?
Yeah. I've taken Mission Save Heart to that. See, my thing was that it's nice to work in large hospitals and wait patients coming. Then they will come and then we will treat. But can we, of the vast bank of knowledge that we have, can we take it to the community?
Exactly.
So of the first heart camp we held was in 1994 in a place called Bundi. I don't know whether you've heard of it. It's a place in Rajasthan. Because I belong to Rajasthan, so from Escorts Heart Institute we went there. And I was aghast that the number of patients who actually had high blood pressure, diabetes, and actually heart attacks.
And this is in the 90s, early 90s.
And this is in the early 90s. And men, women, they just flocked to get an ECG done and to be examined by a doctor. So I said, yeah, if we have to touch the heart of the country, we have to go
You have
out.
to go to the heart of the country.
You have to go to the heart of the country. Don't wait for patients to come clutching their chest and saying, sir, can you do something for me? And I found that the people in the community are not only very responsive, they would like to follow you, follow what you are saying. And in those times there was no podcasts and internet, and so we would have to go to that place again and again, which was not even possible. But wherever I went, and this is where your community of taking messages across this vast great land of ours worked, because Hindi newspapers picked it up, you know, in Rajasthan and other places, and reproduced. But to make an impact, you have to do repetitively, at least for some time. So that's where
repetitively, consistently, and to a very, as you said, you went to one place, you have to go to several places.
Exactly.
So just to add to that interesting point that you raised, every time we do any kind of research on heart related issues, one issue that we hear is that, oh, it's the modern lifestyle, like, you know, post 2000, the change in our dietary habits and stuff like that has had a horrible impact on our heart health. But you are also talking about early 90s, and you are talking about rural Rajasthan, which is hardly a place which would have been touched by
anybody.
Exactly. It was not a place where people were eating Domino's and McDonald's back then. So even then, it was quite clear that the heart issues were
already
India's
there.
Heart has never really been in a
because
good
of
condition.
Our eating habits, lack of physical exercise, lack of just getting checked up. Yeah, please, at least I was getting headaches. At least check my pressure. And cigarette smoking. I mean, BD smoking is men, women, everybody. And people think vaping is good or the pipe is good. Nothing is good. Nicotine in any form. So then several messages arose from the experiences of 1994, 2004, 2014, and we evolved ourselves. And you people also evolved yourselves. That now, while sitting here, your message will go to so many 100,000 people. So, and of course, the change now, you asked about the change that has come in the 2000s. The changes have been very dramatic because people are doing less physical activity, more of processed foods, more of sitting. Physical activity has disappeared, not disappeared, but could have been much better. And smoking in every form, nicotine in every form has increased tremendously. So these are gross changes. And also the very fact we were saying that because of this medium, message goes, many people are on their nets, on their devices up till 2 a.m. and then they say, sir, mujhe neend nahi aa rahi hai.
No, I know, I experienced it
yourself. So, which is bad for health, because 7 to 8 hours of sleep is what the body needs to rejuvenate for the 16 hours where you will be really busy.
Nothing can beat good sleep.
Nothing can beat good sleep. You said it. And if you don't take care of your devices 2 hours, at least 1.5 hours before you hit the bed,
REM is severely disturbed if you continue watching more screens.
Sir, sleep apnea is so common.
I know.
And people say, no, sir, the day I'm tired, I snore, but otherwise I'm all right. Oh, come on, that's hardly an argument. So this is how dramatically the world has changed in the last 2 decades. And sedentary lifestyle has become a way of life.
So in this, it's actually, this brings me not to my direct question, but just something that comes to my mind. Everybody says that we are in the gold age of information. As you said, we can sit here, we can record this, and anybody across the world can watch this interview with you. But we are also at a time when misinformation is at such a level that it's a war.
Yes.
People like you have to probably listen. You probably are aghast when you see some recommendations made by people, and and then we also appeal to emotions by saying ये ancient India में ऐसे होता था और Ayurved में ऐसे होता है. How do you, as a doctor who has dealt with misinformation all your life, how do you think somebody like you, such a veteran, is now coping with the misinformation? For somebody like you, how difficult or easy it is to fight the misinformation or the prejudices that people come with?
No, you're right. I'm straightforward and I'm transparent and I'm clear that this is what I've been doing and teaching and training my students, and also teaching and training my patients and their attendants. And this is what the facts are. You want to read it and verify it, that's up to you. but neither you will have the time nor you will know the exact sources from where this information is derived from. So if you have faith in me, and if I'm saying that, you know, you must do at least 7,500 to 10,000 steps a day, there is enough data on that.
Exactly.
And people many times have come back and told me that, sir, I went to this person and they were pumping something in me, and you said, what is this? I've never heard of it. If I have not heard of it,
Then it's not.
So
authentic.
he said, now I've come back online. And you know, 2-3 things that come very strongly from our disease orientation. We should also be mind oriented. We should also be talking of gratitude, loyalty, physical activities, mental clarity, and positivity. These things also go a long way in giving hormones in the body which work for you rather than work against you.
Exactly.
For example, they say, you know, the normal blood pressure should be 130/80, but we won't start treating you till it is 140/90. Why? They're giving you a great opportunity that non-pharmacological therapy works. You can show it in yourself. That, look, I was hitting 140/90, but because of decrease of salt, because of praying a little bit, meditating, lifestyle measures, and exercising, I brought it down to 130/80. So pharmacological therapy is not for me. And even if it starts, these things will still be there. So I've also been telling people about all these things. You know, somebody very famously said, don't have attitude, have gratitude.
Exactly.
You know, now these are great things. How many people really want to follow it is the point. Are you in the rat race, or you are saying, no, I'm with my family, I'm with my friends, I'm with this guy, my dog, I'm going to follow them. You don't need much courage for that. You just have to embrace them.
So this also brings me interestingly to my next question, wherein your experiences that we're talking, you have helped establish cardiology departments in institutions like National Heart Institute, Escorts, and these are just two that come to our mind. I'm sure you have helped several other institutes. So this is slightly more of a management related question. Like, what key leadership qualities are essential to build successful medical centers?
Right.
It's one thing to be a doctor, but you have also gone beyond merely practicing cardiology to also establishing and maintaining and promoting institutions. So because I want to understand, because I'm sure public policy, health policy makers in the Northeast would really benefit from your knowledge about how to establish, say, a National Heart Institute and something like that in the Northeast. So what has been your biggest lessons in the establishing and scaling up institutions like these?
You know, you should be clear at the very beginning that this is not going to be only a center for treatment. This will also be a center for early detection and for giving people the right knowledge that if your father had it at 55, it's not necessarily you are going to have it.
At 55 years.
Okay, there is genetic history, okay, there is family history, but that only loads the gun. The environment pulls the trigger.
Exactly.
So it should be a wholesome institution where training, teaching, research and treatment, and of course the best treatment for the sick patient should be available at the drop of the hat. For that, even if I have to be with my patient at 2 a.m., I would be there. And also build staff who are cheerful, have good nurses and good administrators who will behave like, no, मैंने ये कहा था,
बाबू टाइप की.
हाँ, सर मैं करता हूँ ना, आप बोलो तो सही, किसने आपको प्रॉब्लम किया है, कुछ देखने नहीं आया, कुछ नहीं आया, I am there for you. These things are important. Now I can't define them, but it's like being the head of a family and taking everybody along with you. Your mom, your dad, your own wife, your children, and yet not look or sound very in a fashion that I call the shots. But in a way, take everybody along with you. Now many people have not liked my way of working, but that I don't exercise my rights as a head of department. So be it. But I work with people just like I'm sitting with you.
So in this case, just a add-on question: how is the talent pool in India when it comes to medical profession? Not just doctors, of course, there are doctors, but as you said, the admin staff, the nurses, the hospital admin staff has to talk to people very differently. Just the mere mannerism has to be very different from a regular, say, a receptionist in a hotel or something like that. So, in your experiences, how has the talent pool been when it comes to medical institutions, and is the situation improving?
Sir, the talent pool is immense. Now, this is where you asked me the first question, leadership. This is where we come in and say, look, maybe you goofed it up, but this is the way to dress up, this is the way to talk. And saying, hello sir, good morning, or hello ma'am, how are you, does not belittle you. Also, the nurses, first thing you do is to greet a patient, then say, can I do something? Nurses are the backbone of any institution. Their one smile will take away half the pain which the paracetamol will take off. So that training has to come, and that is not trained in institutions. But that's okay. They train the scientific part, the book part, and then they come to you raw. You shape them the way you wanted. That's where leadership comes in.
So this also brings me to another question that you have lectured the world over. Some other places, I'm just saying, like Harvard and the London School of Hygiene
and tropical medicine.
And so one thing that I want to is, like, there is the Indian angle, and then there are global perspectives. So what global perspectives on heart health have resonated with you, and how can Indian patients apply these lessons? And in the same way, are your global lessons any markedly different from the Indian lessons, or are they show similar patterns? Because one would expect that.
No, the global patterns show similar. The only thing that they don't understand, and this is your first question, culturally we are different, eating we are different. That's what we have to understand. Why? Because whatever you may say, cut down carbs, cut down this, you have to come and tell them. Okay, roti is roti, rice is rice, desserts which we all love so much have so much carbs. So it's a totally different ethos, but the risk factors for them and us practically the same.
Sugar is sugar across the world.
But the important thing is there is more high blood pressure here, there is more diabetes here, there is more high cholesterol levels here, more nicotine consumption here in our country. So those we have to fire with all guns blazing, because otherwise, if you put a successfully, you saved a guy and did an angioplasty, but if he goes out and smokes, that stent will go.
Same food and
so that's why, let me take an extension of what you said, that prevention has to be divided into 3 clear-cut terminologies: primordial, primary, secondary. Primordial means you tell your child, no sir, all these drinks and all, soda is just once in a while. This says one small bottle has 5 grams, 5 teaspoons of sugar, keep away from it. Same about, so if your child does not develop risk factors, obviously the development of heart disease will be much lower, or not only heart disease, other things also. But your colleague is there, he has got the risk factors, then he has to control the risk factors. Hypertension, get it down, otherwise you will get a stroke and a heart attack and kidney damage. Why are so many people getting kidney transplants? Uncontrolled hypertension in many of them, not all. That is primary prevention. And then secondary prevention, well, you didn't do any of these two. You came to me with a heart attack.
So
then I will tell you now what you have to do. So this is what we have to do holistically.
So sir, we have talked a lot about the need, as you said, from your 90s experience, about reaching out to the people.
Yeah.
And going to hinterland, going to rural areas, because even 30 years ago, it was clear to you that just having a rural lifestyle doesn't mean that your heart is in a good condition.
Yeah, exactly.
So now, even the rural areas have been infected with the problems of urban spaces, like bad food, sedentary, mobile, consumption and stuff. So, like, whether it is a high-tech intervention, or whether it is something as simple or straightforward as screening, going to areas, how does the government as a policy maker ensure that these things are available to the last person, and it is not just like, it does not descend essentially into just medical tourism, which
Yeah.
India is very famous for.
Yeah.
But at the same time, living in the Northeast, we understand how crucial or how difficult it can be to access even a GP. So, for the government, what would be the approach to ensure that at least these facilities are made available in some form or the other to the last citizen?
Absolutely,
also?
sir. Very good question. And that's where the role of the primary health center comes in. We have ASHA workers, we have pregnancies are now being safely delivered.
exactly.
Why can't we have another person alongside tell about tuberculosis, about cholera, about intestinal diseases, and about high blood pressure and sugar? It can be done, sir, if we have a primary health center. But you have to see that they are being manned by doctors and nurses. When patients come, they are almost like temples.
Exactly.
They should become temples of excellence. They just have to sit and talk. That's all they have to do, and minimal examinations. Because anything more than that, they will have to send to the city, which is fine. Because very few will go to the cities. Will require. Most of them, you can tell them, no, see, this is what you have been eating.
They can still be saved with
It
lifestyle
can still
change.
be saved just by a doctor's clear advice that look, maybe you should not be eating so much saturated fat.
Exactly.
You think you work physically, but you aren't. Actually, your tractors are doing most of the work.
Exactly.
And even if you are walking so much, if you are eating such bad food,
No walking can.
it's going to kill the good effects. So I think all around we need primary health. Just like tractor workshops are everywhere.
Exactly.
Then why can't there be
Health workshops.
health work? Now that the government has made so many new aims and so many new medical schools, and they can make much more. After all these people should come back in India and learn medicine here. They are the people of the future. For that, you have to improve the infra of the villages, so that person says, okay, sir, 2 years I would rather go there
Exactly.
and serve my own people. That you have to ensure. Electricity, water supply.
Exactly. Because even with we had done an extensive article about the Health Dynamics of India report, and we found that none of the states in the Northeast have the required number of doctors in CHCs. And you talked about PHC, so the next level will be community health centers. And we found that in states like Meghalaya, for example, they require 112 doctors at the CHC level. They have 4.
Wow. So then,
In a state like Assam, they require 800 doctors. They have barely 200. Mizoram doesn't have a neurologist
yeah.
in the government sector. So, within the medical sphere, do you think that it is becoming harder than ever to access super specialty doctors, or people like you? It's becoming harder than ever, especially for regions like this, where even for something basic you come to Guwahati and the next stop is Delhi. So is there anything that the government can do in the short term? Because of course we can train doctors, but Mizoram, for example, only recently has its first MBBS batch from Zoram Medical College. So we are still very far from developing a network of doctors who have been trained locally. In the short term, what can the state governments do here?
So very good question. I don't know about the state government, but Dr. Naresh Trehan, who is our CMD and with whom I have been associated for many years, has taken this bold step to make a 500-bed Medanta in Assam, in Guwahati itself, which should be functional in 3 years. And I think that can become a model of, the spoken hub model, that we train and send everyone out. And of course, they don't have to then, mostly they don't have to go to Delhi, but the things will be treated in Guwahati itself, in Assam itself. So this is a beginning which we have done in many, many other states. And there the government can also come with us. But many people visionary people like Dr. Trehan, who have made institutions elsewhere, like I was with him when we created the Escort Science Institute. So similar things have to happen now, away from Delhi, away from the metro towns, but to whatever you call tier 2 cities or whatever you call them. But they are people, they are Indians. Now we have to start serving them the same super speciality as we have done in Delhi. And make sure that they are teaching institutes like Medanta, Gurgaon. We have DNB programs in almost 36 subspecialties, and all of them will not stay they will go to the neighboring states.
Exactly.
So the beginnings have been made by many institutions, and this will answer your question. Not today or tomorrow, maybe in a decade or so, but it will make a difference.
Thank you so much, Dr. Kasliwal, for your time. We hope to hear more from you in the coming days.
Sure.
And the next time you are in Guwahati, let's meet up again for another interview.
Thank you so much, sir. Thank you very much. And I'm sure we will meet again, and we will also take up the topics of hypertension and others.
You have been watching EastMojo.com. Please remember to like, comment, and subscribe. Thank you.